Hi, everyone. Welcome back to our last and final webinar for the Radiology Special Interest Showcase. This is session 7, and it will be on education, training, and research. My name is Dr. Azhar Ali. I'm a radiology resident and part of the Radiology Resident Doctors Forum with the Royal College of Radiologists. So the premise of why this webinar was started was because there's often confusion with junior radiology trainees about which direction to take. You may have uncertainty about the future of a specific subspecialty that you're interested in. And we know that training schemes vary from region to region, and often trainees sometimes have limited exposure to certain areas that they might be interested in, and they're not sure about the scope of opportunities available. Or you may be interested in a specialist interest group and not sure what that group may have to offer, especially during your training. So the real kind of aim was to inspire the next generation of radiologists. And through that, this series was highlighted to try and be a series of focus sessions within different subspecialty interests to allow radiology trainees to explore the current and future landscapes of their field. We aim to offer guidance to trainees in making informed decisions about which direction they want to take. We hope to facilitate discussions within these various subspecialty interests and provide insights into emerging trends and advancements. We also aim to try and explore the potential impact of technology, including AI, and we've seen that within various webinars that have been done. But most importantly, to encourage critical thinking and reflection on the evolving role of radiologists in patient care. I want to thank our team, the Radiology Residents Doctor Forum, and our executive committee, without whose help this wouldn't have been possible. And in particular, Dr. Priya Suresh, who will be introduced shortly, Anne-Marie Booth-Sarkey and Amy Steeds, and as well as our esteemed faculty and specialist interest groups who've been very kind to give us their time and talk us through the different sessions. The format has been 7 virtual sessions, and we've covered 14 specialist interests. We have a Q&A at the end, and all sessions are recorded and made available at the end of the program. So these are the timelines of sessions that we've had over the last 7 months. And now it gives me great opportunity, great privilege and pleasure to introduce our first speaker, who will be Dr. Priya Suresh. She is a consultant radiologist and medical director for education and training for clinical radiology. It is a delight to welcome Dr. Suresh. She brings exceptional experience and insights into clinical radiology, with her contributions to education and training widely recognized throughout the profession. She serves as Medical Director for Education and Training in Clinical Radiology at the Royal College of Radiologists, and she also holds key positions as Academy Lead for the Peninsula Radiology Academy, Training Program Director, and Teaching Lead for Imaging alongside her honorary fellowship. Originally from India, Dr. Suresh was the first medic in her family, a journey inspired by her father's hospitalization that sparked her determination to pursue medicine. After moving to the UK, she demonstrated remarkable resilience, successfully passing 6 medical exams and transitioning into radiology. She became a consultant in musculoskeletal radiology, excelling in a field where women were significantly underrepresented. Dr. Suresh has consistently championed better patient care and patient-centered care and diversity within the NHS. As a passionate advocate for international medical graduates, she has led numerous initiatives to support their integration and success within the UK radiology training programs, making lasting contributions to workforce development and inclusivity. We're honored to have Dr. Suresh share her experience and expertise and look forward to an engaging and inspiring session. Over to you, Dr. Suresh.
Thank you. Thanks a lot, Azhar, for your kind words. It's a pleasure to be here. So good evening, everybody, and welcome to the session on education and training. So I'm here to share with you why education and training should be in the to-do list for each one of you. And I hope by the end of the session, we will have many of you taking up, training and teaching as one of the roles in your future as a consultant. So the session plan, what we will do is explore the role of RCR in training, meet the different teams that are working very hard to ensure that we have good quality training. We will also see as to why, how, and what training roles you can actually explore, and what are the different opportunities that the RCR has, and it's also in the wider NHS. So the role of RCR is for training and assessment. That's it's one of its primary roles, and setting up the standards and also advocacy for our members and fellows. We will today focus on the training and assessment that the college offers. So as MDIT, I work with the workforce development and training team, the exam team, and the network team. So these are the three teams that I work very closely with. And we also then interact with the learning team. That is the team that provides the resources for learning and sharing, and the webinars and the other educational resources that is there on the college website. And then the communication and external affairs team that help us get the message to you. When new policies are set up, or there is, like we had the FRCR 2B exam that was introduced, and that team was very helpful in ensuring that we are able to engage all the stakeholders and reach out to all the stakeholders. So today we will focus on the workforce development and training team. The network team, Anne-Marie is one of the members of the network team. So they have done a brilliant job in bringing these webinars together for you. So the workforce development and training team. So this team starts right from the point of recruitment for the trainees. So they advise, there is a steering group for recruitment, and that advises on entry requirement, the actual recruitment process, the CRI, the CR3+, the training expansion, how many numbers, where should they be. Then once you get the number, the enrollment of the trainee is done by this team, and then provision of the e-portfolio, the admin and user support, and also how you can access the e-portfolio clinics. So I'm hoping that you are using all these facilities that are given by the workforce development and training team, because they are there to ensure that you are able to easily access what you need for your training. Now, talking about the numbers, so we talked about recruitment. So the college, and especially in my portfolio as MDIT, we work very hard to ensure that we have increasing number of radiologists in UK. And I think the main workforce is by recruiting ST1s and ensuring that they can complete their training, supporting them to complete their training and become established consultants. So you can see that there has been quite an increase in the number that we have recruited. And this is the hard work of all the trainers, all the heads of schools, and the TPDs coming together to make this happen. Then too, we have a shortfall. So you can see by, the estimated shortfall is still 30%. And by 2030, it's still, at the same range. So we still need more consultants, and therefore we need more trainers and more teachers to educate and train our residents to become consultants. So if you look at the numbers that apply to become radiologist, we are a very popular specialty. The competition ratio this time has exceeded even the surgeons. So it's up to 11.8 or 11.9:1. And we can see the number of trainees that we have enrolled is about 325 new trainees have been enrolled, and 272 CCTs have been recommended. So many people are finishing and completing the training, and we have increasing workforce, but it's not enough. So we still need to work to get more colleagues for ourselves and for the NHS to improve patient care, because the number of CTs, the number of MRs, the demand is constantly increasing. So this is to just reassure that radiology is a very popular specialty, and if each of you think about teaching and training as a role that you want to take, you will have a very significant role in bringing the future workforce into UK. So the other things that this team does is the specialty curriculum development. So we introduced a new curriculum in 2021, and then there was an update that in 2023 we had about the different levels for different procedures. So, and there's also a constant QA process that's being done at the background for looking at how the curriculum is being used, how it is the ARCPs are being done, and how the RSAs actually contribute as external advisors for ARCP. So that's another role that if you take as teaching and training, you can become a regional specialty advisor, and that's a very important role in training and teaching in the college and in the region. They also support the residents to get UPTI, the CCT applications, and if you're changing from full-time to less than full-time, and also advise and support residents, supervisors, TPDs, heads of schools. We have networks of the heads of training. We have networks that we are developing for the college tutors to come together. So a lot of work being done by the college to reach out to the stakeholders. We also ensure that we engage with the stakeholders at the national level. That's the GMC, the Academy of Medical Royal Colleges, NHSC, and other equivalent organizations, to try and make sure that we are influencing training expansion. We are trying to get funding of the training post. We are asking for multi-year funding, and also to ensure that when you are appointed, you have access to equipment in the form of packs, and also rooms for reporting. So a lot of work is going into ensuring that we not only expand the numbers, but do not compromise the quality of radiology that is being delivered. And this actually will help shape the healthcare, because radiology, as you know, is like pivotal to every, like, take any medical or surgical field. Like, you need imaging of some kind. And even I thought, ophthalmology, they do their own. But again, if somebody comes with blindness, I mean, I'm involved with the rheumatologist and ophthalmologist to make sure that it's not GCA that's causing the blindness. So I think if you take any, I mean, we thought dermatology, but then you can get melanoma, you can get some other epithelial carcinomas, and sarcoma. So I mean, I can't think of any branch where you will not be actually using radiology, and it is pivotal in all training pathways. So what are we doing? What else are we doing? So we are increasing the baseline number, like I said. We are asking trust do not have the recruitment freezes. I'm having regular meetings with the heads of services as well, to try and see what is the value of having radiology residents in the departments, and how we can be more innovative. So share good practice amongst the schools to see, how we can maximize the training opportunities, but not compromise the quality. So there's a lot of work that you will be doing if you become trainers and teachers to influence what is happening in patient care at every level. Now, why should you take on teaching and training, and how can you do that? So actually, docure, it comes from to teach. That's what doctor is, and that's where the word doctor came from. So it's one of the fundamental requirements for a doctor, if you think about it. And that's why it's in one of your SIPs, in the generic SIPs, that you have to teach and supervise. So, but what does it bring to you? For me, I feel by helping others, it helps me, because if you actually repeat a concept, you understand it better. Each time you repeat it, each time there is a subtlety that you had, missed in the first reading, and you always become, better at that subject, or at that topic that you're delivering. And therefore, I think, teaching and training should be part of everybody's job plan. It is also important because it improves your team and working environment. Because if you are into teaching, training, and sharing knowledge, there's no barriers, and the barriers are broken, and the team is better functioning if there is clear lines of communication, open lines of communication. And the main thing for me is, I'm actually teaching and training my future colleagues, and it's very heartwarming. It's one of the joys of being a teacher or trainer, when your residents succeed, become successful consultants, become successful leaders, and go on to do a lot more than when they started off as a year one resident. And there is enough evidence in the census data to show that the people that you train, or the residents that you train, usually stay in the region. So about 79%, they become consultants in the training region. And even if you export, you will see them, because we have the Peninsula Radiology Academy, and we have our residents as consultants in different parts of the UK, and they are like ambassadors of the Peninsula Radiology Academy. So even if they go elsewhere to work in UK, that's fine. I mean, it's still carrying patient care in UK, and providing better services for radiology in UK. Whom can you teach? So you can start with medical students. I'm sure many of you are already involved with that. The foundation trainees, we have FY1 with us, who comes for regular sessions, and many of the residents are involved in making sure that they are getting they are benefited from being in the radiology rotation. You can have postgraduate students that you can teach, peers, because there's a lot of peer teaching in the academies, and of course other professionals, because you have sonographer students, you have radiographer students, and we have sometimes physiotherapy students, because I'm an MSK radiologist, that come for our sessions. So and it can influence different and other specialties. Like I have taught rheumatology residents for spondyloarthropathy, or you're invited to teach orthopedic residents for different types of pathological fractures, and how we do recognize them. So you will be teaching different professionals, different groups. And you can also have named supervisors. So you can either be an informal supervisor, that is no requirement for GMC recognition. I don't know, something is wrong with the slide, isn't it? Okay, sorry about that. You can be a named clinical supervisor, which requires a GMC recognition, and a named educational supervisor, which also requires GMC recognition. Now, how can you become and why should you become? So once you become an educational supervisor, it's a stepping stone to the next role that you can take in radiology, in training and teaching. That is, you can become a college tutor, or you can become TPD, or a head of school. I will come to the roles that you can have access to, but it also increases profile, visibility in the department. And like I said, it's a better team if you're all trainers and teachers in a department. And ultimately, a better team equals better outcomes for our patients. And I have actually checked this. When you go, and if you're recognized GMC supervisor, then it says next to your GMC number, this doctor is a trainer recognized by GMC. So, and there's more information available on GMC website, but even your departments will be able to give you information as to how. And year 5, you can start looking at these opportunities to try and become a recognized supervisor. So what are the other opportunities? So we said we can, become ES, CS. So different training roles. So this is how I started. I started as a college tutor. I was a CS and ES before that. And I now currently am involved in the medical school. So I'm a clinical fellow in the medical school. You can become a director of medical education if you go in the trust path, or you can become a TPD, which I was, and also academy lead, because there are many radiology academies in the country now, and then go on to become a head of school. And we have, many of the heads of schools that have now become the MDET. Dr. Stephen Harden, who's now going to become the president, was head of school and then became MDET, and now is the president-elect. And even David Little is one of the heads of school who's now the incoming MDET. So I just wanted to, showcase what are the paths that you have for training and teaching. And if you come to the RCR, you can be an undergraduate ambassador or get elected to the STB. We have one of the residents, Jade, who has actually been elected. So post FRCR, you can be part of the curriculum committee, examiners, part 1, part 2A, part 2B, and also the RCR learning team. So they have leads for the different streams in the RCR learning team. So that is another role that you can take up. And as residents, sometimes I feel that you're not using all the opportunities because sometimes you're not aware of them. There are travel bursaries, even if you are submitting some abstract as a teacher or training role, or looking at quality assurance of a training program. That can be there. There are undergraduate residents. So we had introduced an imaging pathway for medical students in Plymouth, and that was written up and that was presented, and the medical student then went on to win a prize that they could use to present their CV for becoming a radiology resident, and they were successful for that. So there are, from the medical school level, you can start getting involved in teaching and training, and also help the students themselves. We have the Fairer Training Fellows in the college, and they put up a program called REAP that has been very successful. They have introduced reverse mentoring. I have been in the pilot scheme and found it really, really helpful. So basically, you have a resident who is your mentor, and my resident was amazing. So learned a lot from that experience. So please explore that and put yourself forward for that. And currently, Anu is leading on this EDI trainer toolkit, and it's a Bridgie study it's called, and we're trying to develop a toolkit for trainers. So there is work in progress to try and make your roles, if you do choose to become trainer and teacher, better by providing these toolkits and working on what makes a good trainer and teacher. We're also getting the National Subspecialty Lecture Series that will start, in September, and it will be 1 hour series. So I'm sure it will be through the SIGs, and if you are, part of the SIGs, you can be part of, the moderator team, or you can be part of the actual delivery team. And then we have the research day and the supervisor skills day. So like I said, if you do take all these roles, then there is more that the college will do to support these roles. So how can we get involved with the ASIA? Like, Aaron and Azhar, the RRDF is there. So you can start off with that, because RRDF then has its members sitting on the boards that I described. Join the mentoring scheme. RadReach is really good. Think about it. Contribute to the academic journals, insight panels, and like I said, TPD members, heads of school, and this umpteen number of opportunities that you can get. So I think teaching is very noble, and if I'm remembered as a teacher, that will be a real honor. And this is from Abdul Kalam, but I strongly believe in this as well. So RCR is your collective voice, and you are the future teachers, trainers, and leaders. So I hope I have convinced you to, consider teaching and training. Thank you.
I also just want to take this opportunity to thank you for the work you've put in as your time is aimed at. You've been a real champion for education and training, so thank you for all the effort and time you've put into trying to make this role, as good for residents as possible. So really appreciate it. So hopefully you've all had a chance to grab a quick refreshment in the 5-minute break there. So we'll move on to our second speaker now. And we're thrilled to welcome Professor Andrew Swift, who's a professor of cardiothoracic imaging at the University of Sheffield, to our webinar series. And I see your video just popped up there, so welcome. Professor Swift brings exceptional expertise as an honorary consultant radiologist, subspecializing in cardiothoracic imaging, with groundbreaking research in pulmonary hypertension and artificial intelligence applications within radiology. He's got over 200 peer-reviewed publications and an impressive H-index of 52. Professor Swift has made significant contributions to leading journals, including Radiology, the Lancet Respiratory Medicine, and the European Heart Journal. His work has shaped multiple international guidelines and continues to influence the field globally. As a leader in academic radiology training at Sheffield, Professor Swift has secured over £5 million in grant funding as principal investigator, demonstrating his commitment to advancing research through collaborative partnerships with NHS, university, and industry stakeholders. So without further ado, it's my pleasure to hand you over to Professor Swift.
I'm going to talk for the next sort of 20 minutes or so about getting involved with research in radiology. I'm a cardiothoracic radiologist in Sheffield. I'm trying to sort of talk more about the why and how to get involved. I suppose we all know that medical imaging has come a long way since the sort of the early days of Wilhelm Röntgen's wife's hand. And there's been sort of huge developments, really, haven't there, in the imaging acquisition and analysis. It's only continuing, isn't it, with photon counting CT and AI sort of shaping what we do. So I just briefly want to touch on the actual academic pathways that exist for all medical specialities. So we start with medical school, the academic foundation program. So medical school people may have already had done some research, I suppose. Some may not, but there's chances for the intercalation PhD already. The foundation program, I don't think that really worked in radiology, to be honest, unless anybody knows differently. I think it's the ACF ACL training that's the main thing. ACFs having 20%, 25% of their time for research work. There's been a lot of challenges there as well in terms of making the ACF work with clinical training and the exams. So it doesn't work for everybody. It's very challenging, and it's not really optimized for radiology. So you have to kind of make it work in individual scenarios. But so that really is about developing some research track. You can come into it ST1, but you can also in some places come into it ST3, different levels to enter into the academic training, so ACF. And the idea there is to build your research a bit, maybe get a paper and start to work towards actually make an application for a PhD if you haven't got one already. Then you take your time out, do your PhD, come back as ideally as a clinical lecturer. There's also funded. These positions as well are the NIHR funded, come through the deanery, and supernumerary posts. So they can be very beneficial. The idea is that really to try to support your academic training. Then once you've it's quite a sort of challenging pathway to get to go through to academic training, because even once you've finished the academic clinical lecturership, it's no sort of promise that you'll get a university position. Then the thing to do at that stage is, once you've done the clinical lecturership, which is 50-50 research and clinical, would give you the opportunity to increase your academic outputs and try to secure some external funding from a charity or from a national body, NHR or MRC. And once you've done that, and then you've kind of earned your stripes, then a senior position may await in the university. And then you've kind of that's sort of the end of the pathway. But it is quite it's a challenging and uncertain process because you don't know when the funding will come, if you'll get the funding. So you have to have thick skin and just keep going. And there's many different pathways. So people have done this in different ways, and you don't need to follow every single step. You don't need to follow any of the steps really. If you just publish a Nature paper in your spare time, then you might be fine anyway. But I just want to give one example, and lots of people do it differently. But Samir Alabed in Sheffield, he did his undergraduate in sort of war-torn Syria with bullets hitting the medical school. Obviously didn't do the foundation program, but then came to Sheffield to do his academic training, just determined that he was interested in cardiac imaging. Did in the ACF, made a success of the ACF, managed to get through a project some funding for a PhD, and then got onto the academic clinical lectureship, and now is a senior clinical research fellow, but still seeking funding all steps of the way. So he managed to do it, but also he managed to do many other things as well, MSCs and educational things as well. So yeah, it's people do differently. For instance, I didn't do any of came in at academic clinical lecturer stage. Some people might have already done a PhD before, in which case that makes it a bit easier. So it's kind of say there is the pathway, but not necessarily is needed. I'll just very briefly talk about some of the reasons why I kind of got into research, and then talk a bit more about practical stuff. So I think one thing I kind of I have realized is that it really makes sense to play on the strengths of what's around you. So if you and that can come in different forms. So particularly if you are looking after a rare group of patients, or you're doing the imaging for a large rare group of patients, or the clinical team is particularly strong with their evaluations, might be using novel imaging approaches or novel clinical approaches that can be looked at, or there's a group close to you who has very high level expertise in AI or image processing or something. So I think that really stands you in good stead. If you're doing something that everybody else is doing, something very common, then you're really going to have to be doing it above and beyond everybody else. But if you're working in an area where there's sort of that there's a bit of room for you, a bit of time for you to build your track record, then that is helpful. And also the companies that are going to be coming and really managing to probably make bigger headroads in common areas to start with. So you've got to go with the unique strengths, I think. I don't really want to labor on what I've done really. Is but only really to say mainly that in Sheffield there's a big pulmonary hypertension centre. So my PhD was in pulmonary hypertension imaging, and we had sort of the largest population of patients in the UK, and a very, very dynamic clinical team who do very comprehensive imaging evaluations. So it's really paved the way and made it very easy for me to get into and do work. And we published some papers and models, for instance, where you can diagnose pulmonary hypertension using different measurements, which got into the guidelines with high diagnostic accuracy. And then I've jumped on the bandwagon of artificial intelligence, as everybody else is and should do, to be fair, automating those measurements to then automatically make the predictions also more reliably and more accurately on different imaging modalities, and also looking at the different types of diseases as well, and showing actually that the AI can assist by identifying things that the eye is not so good at, like is the left atrium slightly dilated is a hard thing visually to do, but the volumetric analyses that will be coming relatively soon will be able to supplement our practice and improve on our diagnostic ability to detect certain abnormalities, coronary calcification, for instance, something that might get overlooked. It's worth doing it. So yeah, how do you get started? Well, I think you start locally, and as I said, try to identify people doing unique strengths. Ask around. I think that the RCR research map is actually very good. I had a look, and yeah, the people from Sheffield are on there. Didn't see anyone missing. So I think that's a good place. Actually, it's a good place to start. You can see the address there. You can have a look. So yeah, reach out and yeah, exactly. I think people who are doing research, if somebody comes along who's interested, they're gonna bite your hand off, to be honest, to get you involved. So it's a bit of an easy one, really. And I did come across this Crash podcasts from Tom Timsai, and they're really good, actually, very professional, and there's a lot of good stuff in there about academic training and from different individuals in different academic backgrounds. So this was just to say, we've kind of talked about this. You need a specific problem, obviously assisted by you working with interested radiologists, interested physicians. I'm going to talk a little bit about ethics, how to get started, and maybe ways to make it more agile. A research mentor, that could be the supervisor, could be somebody else, and patients. And it is worth considering patients who have lived experiences of the diseases that we're looking at, and they can be quite inspirational as well, and they can also change your perceptions about things, or things you're anxious about. They can change the perceptions. For instance, the patients want you to use their data to in the right way to try to improve experiences for future patients. And they might from their experiences, you do kind of get that personalizes the stories and can shape what interests you in research. There's a different size grants that you can apply for. Obviously, I think you and small grants can be just as hard to get as big grants. I think it can be very competitive, but you have to have thick skin, and you have to just keep going. So you have to keep on trying. You're gonna get rejections. It's kind of normal, but the best thing is to not take one rejection as something that puts you off completely. You gotta see through it, see through the process. The process is that there'll be certain people reviewing the applications who have their preferences. People can always try to conform to the best they can, and also it depends on who else applied at that time. So if you happen to apply at the same time that 10 other people who are already very experienced or whatever apply, then you've got less chance. So you just have to keep on going, because you'll fall on different time periods. So it's just a case of not giving up, essentially. And talk briefly about research data. The difference between pseudonymized and anonymized data. I think mainly I put this because most research starts in radiology, I think, with some retrospective data sets, a retrospective project to look into whatever clinical question it is. And the data needs to be de-identified. And you have to get that process done through an ethics committee, which is straightforward. If you're not doing anything, intervening with the patients, you just have to have a process for describing how you're actually going to anonymize or pseudonymized data. If it's pseudonymized, there is a link key that's kept, and that is also kept in this sort of setting in a hospital, behind a hospital firewall. So the researchers shouldn't, certainly the researchers, say in the university, wouldn't have access to that link document. But if it's fully anonymized, then that would be fully compliant with GDPR, and outside of GDPR, and wouldn't be you wouldn't have the same restrictions applied to it. But you have to also just bear in mind what does constitute fully anonymized. And if you've got a very, very rare disease, clearly that can be identified, then that stuff needs to be considered. But on the imaging, it would be unusual. And just to make sure that the anonymization has been done adequately. So you need to be building in just some checks, maybe, to make sure. It's easy with CT, X-ray, but other investigations like ultrasound, where there's burnt-in information, you have to be a bit doubly careful. Then there's a national opt-out scheme. So patients are invited to consider whether data could be used for research and opt out if they're not interested. So really, we do need to be checking that. If we're doing retrospective research, if a patient has opted out of research, it kind of isn't great to include them in your data sheets. And it's very easy to do. You just email, oh, this is for our hospital, so don't do that. But there'll be an information services at your own hospital, yeah, I think that's that. You might just want to look up the national opt-out scheme for your hospital, how to do that. And I wanted to kind of mention how we handled retrospective research, where we created a sort of blanket ethics that as long as your retrospective project is done in a set way, you don't have to go through full ethics application. You just apply to a committee that conforms to a larger framework ethics that's been done. So that we did sort of talk about maybe trying to make that more accessible scheme. But we'd be happy to sort of share the documentation if anyone wanted to try to set up the same thing in their hospital. I think our hospital is a bit reluctant to sort of just offer to do it everywhere because there would be some administrative aspects to that. But essentially, patients are given a unique identifier. There's a 2-page application that goes to a committee of researchers who sort of check that it complies with the ethics and there's nothing crazy going on. Then the data can be acquired from the clinical records, opt-outs are checked, data de-identified. This is all within the hospital, all occurs within the hospital. That's STH, Sheffield Teaching Hospitals. So it occurs within a hospital. And then the de-identified data is sent to the requester. We use an open source software for the collation of the images. We use XNAT, and it works very well. It's free, open source software. It's very good for putting in the DICOM data within folders. You can see all of the different DICOM series. You can access it. You can even view and make measurements. So it's actually it's very good. And some elements have improved over the years. So I do think XNAT is a very good way to handle your anonymized data in research projects. You can sort of look within projects and see what's there, different series and things. Then make downloads. So I want to touch on AI because I think most of you will have realized that AI is on the up. And we were supposed to be, if AI, after 2022, we were supposed to be already killing patients if we weren't using AI. And we could come out of the dark in radiology and start bonding with patients, was what some of the people were saying. Anyway, so yeah, job center or go and see patients were the 2 options. But I think what really has surprised everybody. Everybody thought radiology would be the first to be taken over, but I think radiology would be one of the last to actually be taken over, particularly with the large language models, which really have so rapidly advanced and really changed everything. And you can see the scale there, a log scale of the data that's available to input into large language models versus it is into medical imaging AI scans. And when I'm saying there, I'm talking about all the information. A lot of it will be rubbish, but the amount of information to understand language and then the amount of information on diseases out there is vast. So it's very, very hard to get hold of vast amounts of imaging data and train really, really amazing models. It's just not really it's not easily achieved. It hasn't been achieved, and that's why the AI models that are out there are not performing at a level that is able to replace radiologists or even benefit radiologists for many examples. Not all examples. Some examples are clearly beneficial, depending on what the application is. But I think this is a challenge for imaging and an opportunity as well to carry on working on different projects and trying to build better cohorts. Because clearly I think it's lagging behind. There's ways to look at papers on AI. There's the claim, this is outdated now. There's different claim 2 and maybe might even be claim 3. I'm not even sure. So I wanted to describe a systematic review that Samir and Ahmed Mehta in Sheffield did, where they looked at studies that had done cardiac MRI segmentation and the reasons why these 250, I think it was, studies that whether they conformed to these standards. And it was just notable the things that were missing, the clinical characteristics were missing or inadequate in such a large proportion of patient studies. So 80% of the studies had very poor information about patients, which says a lot of the AI research in medical imaging is done by computer scientists or engineers or people who are disconnected from the clinical the clinical challenges. And also it means that it's just the open source data that people are using. People are not working with hospitals to access data and do important projects in specific areas to make development. So that was quite a telling observation. Also, there's a lack of external data testing, which plays to our comment about not being enough data available in imaging. Diagnostic accuracy, study limitations. Yeah, no one bothers with that anyway. It's fine. And then then you just get crazy things happening. You get people coming up to you. Some guy came and told me that on their AI for chest X-ray, they could estimate the echo ejection fraction to the nearest 1%. It's just like ludicrous things. Like the echo can't do it to nearest 1%. The echo will have an error rate of 20%. So you just got to be a bit careful. And also the one thing that some people talk about is when the sales pitch comes in, it doesn't come to the people who are actually doing the imaging. It comes to the management with, sales pitch around saving money. But there's very, very, very few, if any, good studies that have looked at the health economic advantage of AI in different pathways. So it does feel like the wave of implementation is way ahead of the actual evidence base for its use. I mean, some things are just obviously useful, like say about parachutes are useful, but still you need to go through a testing process. So I think that kind of concludes it really. To say there's more than one way to get into an academic career. There's obviously lots of resources out there to find people to work with. I think uniqueness is very essential. That will just help you to be successful if you find uniqueness. And we all need to be getting involved with AI research so that it's shaped in the right way. But I don't think we need to be quite as threatened as other other specialities anymore. Yeah, that's it, guys. That's all I've got. Thank you very much.
Thank you very much, Professor Swift. I'd like to invite everybody to the stage for the Q&A. You can see Aaron has logged in and Dr. Suresh. Fantastic. So we have a couple of questions in the chat, so I'll just go through them and then. The first question was for, I think, Dr. Suresh. Can you shed some light on the ST3 pathways for international medical graduates? I know you shared a link, but if you wanted to speak on it.
Yeah, I mean, I think this is a new initiative that was introduced about 3 years ago, and I shared the link, Azhar, because it then tells them clearly what is the eligibility criteria, how you can apply for them. And it's because it's a competency-based curriculum. If somebody has done a lot of radiology, but they should have FRCR Part 1 as minimal requirement, and then they can apply for this. But it is very competitive. There are very few posts, and there are many more residents who want to apply for it. So we are trying to see whether we can increase. But like I said, our main focus is on ST1, because that's where many of the UK trainees will not be able to apply for ST3+. So.
Thank you. And on that note, as you mentioned, we're seeing like a huge increase in competition ratios for radiology training, and yet there is this kind of workforce requirement and lack of consultant radiologists to be able to fill that. So that mismatch between the demand for radiology training plus the supply for consultant jobs, how do we address that? And is there a view to expand training numbers, or what's the college's opinion on that?
Yeah, I mean, we need more radiologists, but we also need to see how we can see whether there's a true demand. I mean, Andy's team as research will come into this to see is the demand really there, like in the sense, are the scans really indicated? Because I think many of it is done because they're following a protocol, and and there are some indications that have been, some guidelines that have been published. But I think there are many other factors that we can look into to see whether we can reduce the demand. But yes, capacity is an issue, and college is working, with NHSC, but now NHSC is ceasing to exist from next year, and there is a national training review that's happening currently. They are going to publish the results of that end of July or something like that. So then we will know if there are more changes. But we are advocating that we need more expansion post, and that will be. I mean, I think there's enough maths to show that having residents is actually saves money for NHS in the long run after 5 years, because in year 3, 4, 5 you become very productive, and it will save money. So, and also, I mean, there has been some data showing that many of those who just come and do the FRCR may not stay here because of family reasons and other economic reasons. So, whereas UK grown residents may continue to be here as consultants. So, I think we know that there needs to be increased capacity, and we are working towards that. But we need more than the 75 posts that they're giving us. So, and we are advocating for that. So let's see.
Thank you very much. Just moving down from the chat, this is a question for Professor Swift. What skills do you think radiologists can start learning to make us AI-enabled clinicians?
Yeah, I was just looking at that. I think I don't know. I think one way you could go is to say, well, radiologists need to learn coding, but actually, I don't really think it's is probably the way forward. Actually, I think you need to be able to understand. They need to disclose how the models have been trained and what's in the models, and we need to be able to understand. It's kind of maybe a little bit like the claim, understanding the criteria when you're judging a paper. You've got to be able to judge the quality of the algorithm. Like if it was only trained in some part of the world where they have very different populations, then it wouldn't make sense to try it here. So it's got to have the right ingredients that would make it likely to be something that would be useful. And then you've got to study that its diagnostic accuracy, like any tool. Its explainability, level of explainability needs to be considered, and then just I think just learning a background of what is AI and how it's working. So it's about an AI enabled clinician. Yeah, I think it's that kind of thing. Probably not necessarily the actual nitty gritty. So in that sense, it's kind of trying to maybe find people. I do find the medical physicists very good. If you in your hospital, the medical physicists know they know the technical side, but they also are receptive to the clinical side. Whereas a computer scientist might be receptive to the clinical side, but less likely on average to be that engaged. So I think better engagement with medical physicists, because we're not likely to just suddenly train everybody in coding and understand. And I'm not sure that's even necessary to be able to work with AI, to be able to code, but to understand about the architectures, the models, the problems where they can occur, the lack of explainability. And I think I suppose it's a bit like going from probably over the next how many decades, it'll be going from generating the information for the report yourself to having the information extracted for you, and then you judge the outputs, and you kind of make the conclusions based off all the information that's been provided, and you quality check. You'd be a quality checker and decision maker rather than somebody who's doing a lot of time making measurements and maybe your eyes flicking around everywhere. You can maybe be a bit more controlled, I guess, which should improve things.
Yeah, I think that's a really good tip, actually. As you say, getting medical physics on board is always useful. We invite them along to our journal club, and it can be quite intimidating sometimes trying to talk statistics in front of people that understand it far better than I do.
Yeah.
But no, it's a really good tip. And just following on from the previous question slightly, do you think what role do you think kind of teaching of AI should have in the curriculum? Do you think it's something we should be formally teaching to residents, or just kind of for now leaving it to the people that have an interest to try and take that forward and then maybe pursue in their consulting careers?
Probably critical evaluation, isn't it, of the tools, if we can be able to evaluate how the tools were trained. So if a software company comes along and tries to sell to a hospital, you can you've got a bit of understanding of what the checklist you need to have for saying that's something that you want. So yeah, how to assess for an AI product, I think would be worth doing, and some basic training on what are AI models and different architectures, networks, and things. I think that would be worth doing.
And yeah, Dr. Suresh, I don't know if you want to come in from the college side of things.
Yeah, I just wanted to. I mean, AI is actually in the curriculum, but we haven't defined what in AI, should be taught to everybody. But it needs to be, like Andy said, I don't think we need to make them all coders, but they need to understand what are the limitations, what are the biases that the AI product can have, and why it is not suitable, or why it is suitable to be used in their department. So I think that's what that's the knowledge that each radiologist will need to have. And also when they use it personally, like what are they actually missing, and what are the blind spots that the AI tool is having. So I think we have contacted the AI committee, so we will be soon outlining what actually all radiology residents need to know about AI, because I don't think it's something that you can ignore.
Yeah, absolutely. And it was nice to see the recent AI conference by the Royal College this year. I know a few trainees who went and attended it. So it seems like there's a drive for better understanding within the radiology workforce on how to actually perceive these technologies and, like you said, and decide whether they're useful or not. So yeah, that's quite useful actually.
I also think we may need to be the drivers of the education in some ways as well. So, for example, our trust uses CT head AI analysis for strokes, and quite often it will kind of flag kind of false positives, and we'll get people coming to us and saying, "Oh, look, they've got a stroke," because the images upload straight to PACS, kind of flagging up these areas of brain, and you have to kind of explain to them why it might not be a stroke. And I think if we need to understand it to be able to educate and teach the other specialties as well who may be interacting with these tools. So another question for Professor Swift from the chat on a slightly different topic. I've heard ACFs are incredibly competitive to get into, with most successful applicants already having a PhD under their belt. How would you go about obtaining a PhD outside the ACF role, and what time point would be best to take a break from the program to do a PhD?
It's good. Yeah, it's a good question. Needs a lot of thought. The ACFs have become more competitive, I've noticed actually recently. But it's anecdotal, but have become more competitive. There were 40 applicants for the last ones that we did. And maybe 5 really top candidates. I'd like to think actually that having a PhD shouldn't actually be absolutely necessary. It is advantageous, but this person should be judged on their trajectory at the point where they're at, as to how good they are. So somebody who has got who's done less time of research should be judged differently to somebody who's done a PhD as well. Because sometimes someone could have done a PhD and then done lots of things, but then it's just a relative scale. So they might have done this much, but you would expect them to have done this much. So it shouldn't always be judged like that. But clearly, if you've got a PhD, it's still going to have some kind of advantage, isn't it? So I mean, there's an element of luck, isn't there? Who happens to have funding around? Does that fall within your interests? Asking around a lot and getting involved with different research groups might be a good way to go. And then you might fall in at lucky times. What happens where they've just received a project grant, or they're planning a project grant. They've got you in mind. They can even build you into potential projects that they are planning to submit. So it's having those relationships with the research groups, get you on their mind, and then and yeah, exactly. So that can be. And then if you can get with a research group and publish something with them, get involved with them, then there's opportunities to just write a PhD application without you being on an ACL program. I don't think the ACL the program is to facilitate the research, but it doesn't mean to say you can't succeed without it. You absolutely can. And then you take it. I don't know the best time. I think is I don't know when the best time is, because it always depends on personal circumstances and everything. When's the best time? I mean, it's sometimes from some points of view, it is better to do it later. Once you've already decided on your area of interest, then you do your research in that same area, and it's a nice track through to progress the research. But equally, if you do it earlier and you do a different thing, it's still transferable skills. So I'm sort of arguing anything basically. You can do anything. But the more people you talk to, the more research groups and see what interests you. That's probably the best way.
Thank you very much.
Thank you very much. And yeah, I don't see any other questions in the chat. It's just I've maybe got one more for Professor Swift, unless Azar, you've got anything else you want to ask. I was just wondering, so we've talked a bit about, you've given some really interesting information there on kind of how to do research and kind of the process to go through. How do you then find the kind of the next step in terms of bridging the gap between the research you've done and the clinical application? How do you try and translate what you do into kind of real world use and applications? Is it something you kind of tour around major conferences trying to present as many places as you can, or just try and implement things locally and hope it kind of naturally diffuses?
I think yeah, that's really important. So that's the difference between just doing some research and then it gets buried in the literature, and actually trying to do something that makes a difference. So trying it locally is good, and if you work with your, say, whatever it is, informatics, whatever team, clinical, medical physics or clinical informatics or whoever, to implement something locally, you can do that. You're still supposed to conform to kind of a regulatory framework, but there is an in-house exemption for people who develop things locally and use them in their hospital. So that does allow you then to potentially try things and to get some data from use of your tool in the hospital. But if you really want to have a bigger impact, then you need to get your tool adopted by a company, or you need to create your own company to do that. And yeah, that the reality is, if you really want to see the thing being used in clinical practice, they've got those options. And yeah, or it could be your research just literally just gets picked up by others. So it depends on how whether you really want to see your research delivered, or you just sort of diffusing the information. And that happens a lot with open source. So if you do create a tool, make it open source, it allows others to use it. Like Total Segmentator is a good example of an open source tool lots of people are using to build other tools on top of, because it's just a segmentation. So then you can do other things on top of it. So there's a lot to learn around that, around the regulatory side. But there'll be people in everyone's hospital who does have an awareness of that, and a lot of the departments work to certain standards. Actually, some clinical like clinical engineering in Sheffield has a system where they have a quality management system, and they work to a certain level of some standards. And if you can kind of fit into that, then your product, your tool could be developed like a product that has a backstory to it, and you know where all the data is, and they have all there's like probably thousands of forms you have to fill in. Yeah, so you can kind of go to that extreme, or you can just publish, try and get your stuff out there, open source, and let other people pick it up.
Thank you.
Thank you very much. Thank you very much, Dr. Suresh and Dr. Swift. I would like to invite Dr. Stephen Harden, who is the current Vice President of the Royal College and incoming President of the Royal College of Radiologists, to deliver the closing remarks for our webinar series.
Thank you very much. Can you hear me, Azar, all right?
Loud and clear.
Yeah, great. Evening, everyone. I just want to say a few words. This marks the end of this special interest series, and it's really been a great success. We've pretty much covered all the anatomical areas of radiology from head to toe, not just singly out neuro and MSK, but actually extending into some of the topics we've heard today, including research and education. And I think it demonstrates that number one, how big radiology is, but number two, how much choice you have. There will be an area of radiology for you in which you excel and which you enjoy. And I hope this series has given you a taster for that. And actually, the work that we do throughout a career does change slightly. It doesn't usually change substantially, but actually, there's always something else you can go off and do and maintain your interests and maintains our focus on patient care. This series, we have had some speakers of the highest quality, including, of course, Dr. Suresh and Professor Swift, who you heard this evening. It's been very popular. We know that because we've had 400 registrations. 14 of these lectures have been provided across 7 sessions, and the feedback that we've had from you is excellent. All of these are available on the website for any that you've missed or any of your colleagues that would like to catch up with them. This has been an initiative conceived and led by the RRDF, and I think it's just evidence of the fact that we're all one college, and actually we're here to support you, and this is a great example of initiative, actually something that will really support you as resident doctors really well in helping you then move to the next level in your career. I do particularly want to mention the executive committee of the RRDF, 2 of whom, of course, are here this evening, but particularly Erin Taylor, Sophie Wilkinson, Azhar Ali, Honida Mansour, James Fish, Lee Warburton, Lydia Earnshaw, Marcus Belasco, and Scott Robinson. And this is very much your initiative, and many congratulations on what's been a really successful initiative. Just also to mention some other really critically important people behind the scenes, Anne-Marie Booth-Sarkey and Amy Steeds have very much led the organisation of this. And particular thank you to Priya Suresh as the outgoing Medical Director for Education and Training Clinical Radiology. I say outgoing, got a couple of months left to do Priya, but actually Priya's been an enormous support to all CR residents. A lot of it you don't see, but she's constantly fighting to make sure that you get you get what you need and you get the best arrangements to allow you to really flourish. So a huge amount of really dedicated work across the last 3 years. So thank you very much, Priya. And just a final word, I mentioned that this is resident doctor led. We'd just be really interested not only in your feedback from this evening, but any other ways that you feel that we could help support you in your career now and in the future. Any other ideas you might want to feed through to us directly, you can come through to Priya or I as college officers. You can come to the JRF exec, including Azhar and Aaron, or your own local, what was JRF, now RRDF representative. Please let us know any ideas of what you think we could do better and how you feel we can best support you. So thank you very much. Thank you very much to the RRDF exec. And I might just hand back Azhar for a final few words, but many congratulations to all of you. So particularly to Azhar and Aaron this evening on a really, really successful series of sessions.
Thank you very much, Dr. Harden. That's an honor that you've spoken about and given some closing remarks. Yeah, no, honestly, this has been a privilege and a great series. And when we first decided to do it, it was just an idea, but it was really heavily supported by the Royal College, and that's why you can see it attain fruition today. So and the host of speakers we've had, if you've missed any sessions, please log in online and you'll be able to see them. And please do fill out the feedback form, because that just helps us improve, especially for next year. And like Dr. Harden said, any ideas you have on future projects, we'll be welcome to see them and try and facilitate them through the Radiology Resident Doctor Forum and the Royal College. So thank you very much, and hope you all have a good and lovely evening.